Welcome to the ASCO e-learning weekly podcast, a weekly educational series focused on helping learners identify knowledge gaps and stay up to date with the latest in new drug developments, cancer treatments, and patient care approaches. This episode is complementary to an education session presented at the 2019 annual meeting. For more detailed information about the education session, make sure to check the episode description for links to ASCO's meeting library.
Our next speaker is going to speak on Whose Breast Is It Anyway? Breast Cancer and Sexuality in Sub-Saharan Africa by Dr. Yehuda Marti, who's a graduate of Yale School of Medicine. She completed her internal medicine residency at UCSF and her hematology-oncology fellowship at the University of Pennsylvania, where she's now a medical oncologist and a global health scholar. Yehuda currently lives in 2 countries, the US and Botswana, which allows her to conduct important research work focusing on improving cancer medicine access and optimizing therapy delivery and treatment outcomes for breast cancer patients in sub-Saharan Africa. Please welcome Dr. Marti.
I remain perplexed that when a woman is diagnosed with breast cancer in parts of sub-Saharan Africa, and she has the choice to undergo a mastectomy, everyone in society has an opinion about this. This includes her husband, who threatens to leave the marriage if she mutilates her body, to other women who judge her and see her as less of a woman. So the question I ask is, whose breast is it anyway? In 2008, as a medical student, I met a young breast cancer survivor in Ghana. And she told me that when she was initially diagnosed with breast cancer, she refused a mastectomy because she thought it would diminish her potential for attracting marriage suitors. She explained that a woman with one arm or one leg is more likely to find a husband than a woman with one breast. And because of that, she'd rather die with 2 breasts than live with one. I was shocked because I thought striving for survival trumped everything else. And I'm embarrassed to say I judged her as well, because I thought, what woman in the 21st century would choose marriage potential and sexual desirability above advocating for their own health? Fast forward 10 years later, so a year ago, I was watching Breast Cancer Awareness Month events in Ghana. And a man was actually interviewed on national television about his views on breast cancer and the surgical management of the disease. And he said in Twi, which is a common Guinean language, "I will never allow my wife to cut off her breast. That is not possible because one breast is mine and the other is for my baby." As crude as that sounds, I think it highlights the complexity of delivering care in sub-Saharan Africa. But it's also this complexity that challenges me and inspires me to try to understand some of these barriers in an attempt to deliver high-quality care. So what do we do? I believe that recognizing that this complex social-cultural dimension influences the decisions women make about treatment is important in the regions where we practice. It's also important to realize that women are not to blame, and that this self-perceived stigma is a byproduct of a more systemic societal view of sexuality in sub-Saharan Africa. As a society, we have placed such a high premium on marriage, to the extent that when a young woman is diagnosed, she wonders how pursuing surgical treatment will hinder her ability to attain that potential. And there's the added apprehension for women who are married of not only losing a husband, but potentially losing financial support for children in the marriage. Africa is still very male-dominated. And although traditionally breast cancer awareness events and education have targeted women, That needs to change. We need to partner with men and also influential leaders in society. So this includes our community leaders, our religious leaders, our traditional leaders, to leverage their position to try to change some of these norms and beliefs and advocate for women's health. Is it going to be easy? I don't think so. In fact, I look around and the fight for women's health rights remains the fight of our lifetimes. And so I have no illusion that this is going to be easy. But it is necessary. I think other solutions should address the body image. And so in sub-Saharan Africa, in most parts of sub-Saharan Africa, more than 50% of the women who are diagnosed with breast cancer are actually diagnosed before the age of 50. And the most common surgical option available to most women is a mastectomy without reconstruction. So you can imagine the added psychological burden for young women diagnosed in these regions. And so an obvious solution might be breast reconstruction. But I think it needs to be partnered with good research to make sure that it's feasible, culturally acceptable, and actually accessible to women in these regions. At Penn, we liaison with local organizations to donate breast prostheses in areas where we practice to breast cancer survivors. I have been humbled as a global oncologist by this experience. And I'm humbled by the fact that I knew very little about how society interacts with medicine in a society that I grew up in and lived till I was 18. It's also shown me that the success of global oncology is more than just transporting what we know has really worked in developed countries into developing countries, and that there's a need for qualitative research, for anthropological methods, to start to understand some of these behaviors and beliefs. There's also a critical need for implementation science to systematically study how we adapt some of these guidelines and treatments that we know really work well, so they're culturally sensitive and resource specific in the areas where we practice. And for majority of you in the room who don't practice global oncology, I think this is relevant as well, because we live in a time where the world has come to us. And so regardless of where you practice, we have the privilege of treating a diverse and multicultural group of patients. And it's important to understand in a clinic visit that for some of these women, the breast cancer experience involves subjective and social cultural elements that affect how they perceive themselves. And I believe that if we can understand even just a fraction of that, it'll put us in a better position to deliver holistic care to the patients that we treat. Thank you so much for listening.
Thank you for listening to this week's episode of the ASCO eLearning Weekly Podcast. To make us part of your weekly routine, click subscribe. Let us know what you think by leaving a review. For more information, visit the Comprehensive eLearning Center at elearning.asco.org. The purpose of this podcast is to educate and inform. This is not a substitute for medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.